Okay. So there was a question if you're responsible for knowing about DKA and HSS, right? That is going to be covered senior year. So that's not something you need to know about for this year. Thank God. Yeah, no kidding, right? Okay, I just went to go get my coffee, heated it up. It's freezing at the bus stop, guys. All right, so we are going to be covering. There will not be new style questions on the exam. Then that's not going to be on. Probably you won't be seeing those until senior year, but you're going to be having activities that have some of the NCLEX style questions. You're welcome, Sonia. Okay, so as you probably have got the gist, I'm not sure about the ATI platform. We're meeting today to discuss that. There will be an announcement about that for Tuesday's exam. Okay. So as you probably got the gist, during Nursing 120, you guys got some introduction for different concepts. And now we're going to be reviewing the concept in a little, very brief discussion. And then we build upon the knowledge that you guys have learned. And then we talk about the exemplars for that concept. So you guys received an information about the concept of metabolism and regulation previously. We are going to be building upon the concept of metabolism and talking about gestational diabetes and peripheral neuropathy. Okay, so before we begin, I want to do a little fun little game. Somebody's going to tell me a fact that they remember about diabetes, type 1 or type 2. And the rest of the class is going to say, is that the truth or is that a lie? Okay. Just a nice way for you guys to rehash and think about things that you guys remember from last year's discussion. It also helps to show you that you guys did learn a tremendous amount about diabetes already. Okay, does anybody want to state a fact about diabetes or something? Okay, so Logan says the islets of Langerhans. Oh, let me go back to here. Langerhans B are responsible for the insulin production. Is that correct? Everybody agree? True. Okay. Excellent. All right. Random blood glucose should be between 80 and 100. Anna, what do you guys think? Is that true or false? Okay, false. 70 to 100. Okay, yep. 80, usually when we see blood glucoses, we expect that somebody is going to be running between, I would say 60 to 100. And usually that's fasting. And I'm not sure if you meant what random, meaning before meals or not eating. That would be the difference. Okay. Lispro is a long-acting insulin. True or false?
False.
False. Excellent. What kind of insulin is Lispro?
Short acting?
Okay, good. Which means it's going to work relatively quickly, right?
Yes.
All right. Does anybody remember a type of long-acting insulin? Detamere, Lantus, gargling. There you go. Good job, guys. Excellent.
I got a true or false one. Type 2 diabetes can be cured. True or false?
So everybody seems to be putting that it's false. Does anybody can be managed with lifestyle? Okay, you can reverse through. I'm going to agree with Stephanie. Reverse through lifestyle modification, but not cured. Diet and exercise are going to help you not need medications. So type 2 is the one that you can, actually even reverse and not need to go on insulin, or you're not need to have an oral anti-diabetic medication unless it's gotten to be too severe. Does that make sense? You're going to use diet and exercise, and because it's the sedentary lifestyle, the poor meal choices that impact it. But it also can be genetic, so it can be something that might be challenging for people. Okay.
I have a question. Metformin is used to treat type 1 diabetes.
Okay. You think? Is that Chris who has made the question?
It's false, yeah. It's for type 2 diabetes.
Yeah, there you go. Excellent. So that's very important to know, because remembering with type 2 diabetes, that's when we use the oral medications. And with type 1, the patients need to have the insulin. That is correct. Great job. All right. Any other thoughts or things that you remember from diabetes?
I remember the rule of 15.
Excellent. And what is the rule of 15?
Like you try that first before you give the patient any insulin, like the crackers, the sugars, the apple juice and so forth. I remember everything, but I know you tried that and then wait 15 minutes and try it again. And
Yeah. Recheck the temp. Right. So if we have a patient who has a low blood sugar, they have to be alert and awake, right? We're not going to give it to somebody who's unresponsive, because if they're unresponsive, we're not going to give them anything that by mouth. We would be giving them IV dextrose or a Becemme, where's the nasal spray that we put in their nose, just as somebody who had a Narcan overdose. But if they are awake and alert, we will check their blood sugar. If it's low, we will give them 15 grams of a carbohydrate or something, and we will wait 15 minutes, then recheck the blood sugar and repeat again in 15 minutes if need be. Okay. Metformin side effect is diarrhea. Yep. Okay. And type 1 patients tend to be skinny due to the fat breakdown. All right. The difference between, we remember a blood glucose, a finger stick, we're checking the blood glucose as what it is at that moment in time. That's what most of you are doing each week in clinical. And the hemoglobin A1C is a blood draw, which measures the patient's average of their blood sugar over the last 120 days. Yes, so elevated hemoglobin A1C is indicative of diabetes. And that's important to know, because that's some of the things that we are going to be looking for and talking about this semester. And building upon it when we talk about gestational diabetes. Okay. Right. So first few slides, just a review of the endocrine system in the pregnant woman. So we just want to, make sure you read over that on your own. We're not going to talk about that in great detail. But just know that because a woman becomes pregnant and is expecting to have a child, the body endures some changes. Especially with the hormones, and it can affect the person's metabolic state. And it puts the person at greater risk of developing gestational diabetes. Okay. So when a person develops gestational diabetes, what I want to make sure everybody understands is this is a person who does not have diabetes prior to becoming to conceiving. Okay. So it's being pregnant that actually causes the person to experience elevations in their blood sugar. Okay. Women who have diabetes or insulin resistance, such as having polycystic ovarian syndrome, run a greater risk of having gestational diabetes and having an issue during pregnancy. Okay. So when a woman has gestational diabetes during the entire pregnancy, or a person who has diabetes prior, they're going to need additional testing and treatment. I would say women have pre-existing metabolic conditions prior to conceiving need additional testing and treatment prior to consumption. Why? Because women who have polycystic ovarian syndrome or insulin resistance are going to have a harder time conceiving. Okay. So that it gives them issues with fertility and conception. They are also going to need closer monitoring during pregnancy. And what type of testing do you think we would want to be checking them for? The hemoglobin A1C and their blood glucose levels. Exactly. Perfect. We're going to look for urine, glucose in the urine. We're going to do fasting sugars. We are going, and you guys learned that glucose tolerance test. Yes. Did you guys learn about that when you talked about the maternal child? If not, we're going to go over that anyway. Okay. All right. So, when a woman who has metabolic conditions prior, pregnancy may resolve or worsen the pre-existing conditions, or change during the requirements during pregnancy. Okay. Preconception counseling is an important thing for us to look at. We want to make sure that the expecting mom, has good glycemic control. Okay. Just as our type 1 or type 2 patients, we are going to want to make sure that their blood sugar stays within normal limits and as close as possible. Because when a woman is pregnant and has poor glycemic control, they are at higher risk of complications. Okay. They can have a spontaneous abortion. The baby may be born with congenital anomalies. They may experience preeclampsia, intrauterine fetal demise, which meaning that the baby is older when it does pass. The key thing about babies who are born to moms with gestational diabetes or a pre-existing condition of diabetes is that the babies are born to be very big. Okay, that's called macrosomial. Babies cause a lot of challenge for the mom to pass. Do you hear it still?
I think we lost you for a little bit. It went static and then you left.
Oh, okay. Can you hear me now?
Yes.
Okay. Where did you lose me? Did you hear macrosomial?
Yes, that's kind of right where that ended.
Okay. So the babies who are born to moms who have gestational diabetes or good try, Robert. Nice
You did
try.
it again.
Oh, no, Robert, he said, I was reading his question. He said, we lost you when I was giving him the test answers. The answer to number one is C. The answer is always C. Okay. So macrosomial means that the baby is very big. Um, and that happens because of the amounts of blood sugar. Okay. And when we have a baby that's born very big, has complications for the mom too, not only the baby. But trying to pass a 10 or 11-pound baby isn't going to be very, very easy. So what do you think puts the mom at risk for?
Hemorrhage.
Hemorrhage, yep.
C-section.
And C-section, yes, exactly. And if they try to deliver the baby normally, the baby can have some, dislocations or broken bones, may get stuck. Lacerations, definitely. There you go. Just thinking about the tearing of this would be makes me hurt. Your babies can also experience hypoglycemia after they are born. So you're going to see that they're going to have trouble regulating their blood sugars and dropping their blood sugar. So it's going to be important to frequently monitor their blood sugars and check and make sure that they're getting enough food with each feeding, right? We don't want a baby to become hypoglycemic. And babies can also have hyperbilirubinemia. I'm sorry. It's a tongue twister there. Sorry. So the target hemoglobin A1C is going to be that we're going to try to keep the hemoglobin A1C between 6 and 6.5. Sometimes we will allow the hemoglobin A1C to be a little bit higher because we want to make sure that the mom isn't experiencing any type of hypoglycemic events. So we want them to eat a little bit more, okay? Moms who have gestational diabetes or other condition, or sometimes just a regular mom, they always think that they're eating for two, right? We don't want them to think that they can eat whatever they want because that's going to make their blood sugar levels and their hemoglobin A1C much higher. So it's going to, the question is the hemoglobin A1C 7, but nothing above, right? It's average. We want to try to keep them as close to 7 as possible, all right? Nursing is not just 7.1, now we've got a problem. We want to try to keep it as close to that as we can. Okay. Sometimes you will see that a person has sickness, and so their sugars might be up for a period of time. They might have some emesis or morning sickness, so they're not eating or drinking as well. So we want to make sure that they eat during that time, and sometimes they can't. So it's well above 7%. What would our course of action be? Well, what do you think we would do for a mom who has hemoglobin A1C of 7? Insulin. There you go. And Stephanie, the rule of 15 is not going to apply here if we're thinking that the blood sugar is high. Okay. Yeah. All right.
But like
if
that's
the mom
usually determined like during like a checkup. They're not necessarily in the hospital. So would you be sending them to the ER or to see their PCP? Like, you know what I mean?
for what? If they had a hemoglobin A1C
Yeah.
over
Like if
the
it was
over
above
7?
7.
Yeah, so this isn't a critical thing to have a hemoglobin A1C. It's going to, you might have some some complications that arise, most of the time your women who have gestational diabetes, who are pregnant, aren't going to be in the hospital unless they're having very hard time maintaining their blood sugars within a reasonable range. So if they're experiencing hypoglycemia, or if they're experiencing very, very, very high blood sugars. Okay. So thinking about the hemoglobin A1C, that's something that is looking at an average of 120 days or three months, right? So they are not, that's not like an urgent lab result that we're going to see. That just tells us that, hey, you know what, over the past few months here, you're 3 months pregnant here, your hemoglobin A1C is very, very, very high. It's very high. We need to make some modifications, and we may need to start insulin, or you may need to increase your exercise, or you may need to turn around and modify your diet more. Okay. And so that's what we need to turn around and look at and think about with the hemoglobin A1C. It's an average. Okay. Women who have gestational diabetes are also at greater risk for developing diabetic retinopathy, which is trouble with their vision and can lead to blindness. Okay, so you're going to want to make sure that they are following up with their ophthalmologist. Okay. Given the okay. All right. So we're going to talk about the medications that are safe for just pregnancy in a few slides. Okay. All right. So what is gestational diabetes? It's a carbohydrate intolerance that has variable severity that begins when the person becomes pregnant. So anybody who is not conceiving cannot have what? Gestational diabetes. It can be a result for pre-existing conditions. It can be an exacerbation of metabolic problems that we've had in the past due to the increased amount of stress that a woman experiences during pregnancy, right? It also can be a direct consequence of metabolic changes in the hormone levels, right? When you have gestational diabetes, it increases the risk of morbidity, mortality in the unborn child. And it also puts the mom at risk for developing diabetes type 2 later on. Right? So it is a problem with the metabolism of carbohydrates that affects the woman during pregnancy. And in the second half of pregnancy, a woman can experience prolonged episodes of hyperglycemia, hyperinsulinemia after eating, and it puts them at risk for needing the insulin. Okay. The problem with pregnancy, and I think I started to mention it, is that if a mom experiences morning sickness, they're going to have nausea and vomiting. They're not going to be taking in as much food as they have, and they could wind up having the other end of it, hypoglycemia or insulin shock. So we have to look at what's going on with the baby. Okay. Diabetes can be more controlled, more difficult to control due to the changes in insulin requirements. Insulin needs may decrease early in the first trimester, but it may double or triple closer to the end of the pregnancy, right? The patient is at increased risk of developing hypertension, neuropathy, retinopathy, and ketoacidosis, right? A woman who has diabetes carries a higher risk of complications. We talked about that. Risk of mortality and congenital anomalies can be reduced significantly by making sure that we have a better glycemic control, utilizing insulin to control those levels, and not using any medications that have a risk of impacting the baby as they grow. All right. Definitely going to do a lot more monitoring. If anybody has a child and hasn't had diabetes, you go pretty randomly to the doctor. If gestational diabetes, you may go very frequently, weekly sometimes, for stress tests to make sure that the baby is doing well as well. But for the most part, this is all going to be done and monitored through your OBGYN and as an outpatient, again, unless the mom has any complications. And so what are the risks for having gestational diabetes? You can have hydrodramenose, preeclampsia, ketoacidosis, difficulty with labor, retinopathy. And another thing that happens frequently with a mom who has gestational diabetes is yeast infections or urinary tract infections. And can anybody guess why that might happen?
They like sugar.
Like sugar. Yeah, you got it. The higher sugar levels in the urine makes them more prone to urinary tract infections. Okay. Not sure where my pictures, my information is on this side here. But there is a lot of risks to the newborn baby. They are going to be born very, very big. And I think we talked about some of the complications already. Let's see. All right. So what are we going to do for a mom who has gestational diabetes? Okay. You're going to be doing a lot of screening. So every woman who is expecting is going to have a standard screening for gestational diabetes. They're going to be checking them, and they're going to be looking to see what their hemoglobin A1C is. They're going to check their fasting plasma glucose. And if there's no pre-existing conditions, such as diabetes or anything to be concerned about initially, they're going to check them at 24 to 28 weeks. Okay. If there's any concern prior to that, can they check them? Yes, they can. But this is talking about a woman who hasn't had any issues or any complications. This is a routine screening that they're going to do between this time. Okay. What is a myelomeningocele and encephalopathy? Okay. So those are birth defects that will occur if side effects there. So you don't have to memorize them. I just kind of put them there. But encephalopathy and hydrocephaly and all of those complications, you probably learned about them when you talked about the newborn assessment with Dr. Murphy, but that's when they were born without a brain, or the hydrocephalus is the water on the brain and the head is very big. I don't want you to have to worry about all of the conditions that can happen with that, but just know that there are some pretty significant birth defects that can happen when a newborn, when a child does have a mom with gestational diabetes. And that's why it's critical to make sure that we monitor the blood sugars and keep them under control. The gestational diabetes will generally resolve once the mom delivers. She may have a greater chance of having diabetes later on in life, But if the baby is born with these complication, it can be life altering and very traumatic, you know, for parents to have a child that is born with some of these complications. It can be, you know, devastating to find out that your baby has some of these birth defects. They also will probably do genetic testing, um, you know, if and see how things are going. Right. So one of the things we talked about was that they're going to do an oral glucose tolerance test, and there's two different ways, and you guys wrote down right between 24 to 28 weeks. Um, the mom is going to be ordered a oral glucose tolerance test, so they're going to get a slip, a paper for them to go to the lab. The mom is going to fast overnight, and she's going to come in to the lab station, and she's going to drink about 75 grams of sugar. It's like an orangey little syrup. Tastes great. Some people don't like it, but they are going to turn around and then check the mom's blood sugar 1 hour after drinking the syrup, the little solution there. And then they're going to check it again after 2 hours. Orange, lime, fruit place. Oh, okay. See, I'm dating myself. When I was 5 years ago, we only had orange. I didn't mind it. Okay. But you do have to sit there for a couple hours, at least 2 hours. And what is indicative when the mom comes in is that the blood glucose, and she's fasting, is greater than 92. Or at the 1 hour interval, it's greater than 180. And at 2 hours, the blood sugar is still elevated about 153. Okay. I drew the vodka. Goodness, Ryan. All right. Probably not if you were expecting, because then we're going to talk about different fetal alcohol syndrome there. All right. So these are just a range that your book uses. Labs, can they use them differently? Yes, every lab might have a different range, but for testing purposes, this is what we're going to. Yes, I would say that you would want to memorize these lab values, or at least have a good understanding of where it is, right? So what I want you to take away from this is your person comes in, they should have a normal blood glucose level, right? 92 is going to be a little elevated for them when they're fasting. And then what they're going to do is drink that sugar. So what your body, you will normally do is it's going to spike, but it should start to return down closer to normal within 1 hour. And it should be even closer to normal within 2 hours. So that's why they're going to use these numbers as a guide, because it's still elevated after drinking the drink, right? They can do another 2-step approach with that. Are these values different for the glucose tolerance? Usually fat. Yes, this is different. These are the values that your book has in there for a range. Okay. So with the 2-step approach, so what would the difference be between the 1-step and the two-step? Most commonly, you're going to see that the 1-step approach is used. Okay. Sometimes if they fail the first time, they might do the second step, right? And that will give them another day to go back and to drink some more, right? So when they do the 2-step, because they failed the first step, they are going to get 50 grams of the drink, and it's done non-fasting, and then they're going to have their blood work drawn within an hour. Okay. The second step would be that they are going to have a repeat test done where they have 100 grams of the drink. They wait 3 hours, and they're going to have their levels drawn. But when they have the second test, they're going to be able to eat whatever they want for the first 3 days. They're going to drink the drink, and then they're going to have blood work drawn at hour 1, hour 2, and hour 3. Does that make sense? So it's not critical that you memorize how much glucose that they're having, and when they're, what they're doing. What I want you to take away and know is that when you have higher sugars at above usually 180, 155, or 140 for this second test, very similar to the first step. So you don't have to really fret too much about the range difference between test 1 and test 2. Just knowing that a high sugar at 1 hour, above like 180, 190, 2 hours, 153, 155, and 3 hours about 140 for either of the tests is going to be indicative that the person might have gestational diabetes. Can you explain failing the first test? What makes the test a failure? It's not getting an A or B, right? Okay. Failing the test means that when you go for the glucose tolerance test and your sugars remain elevated at the 2-hour mark and it's high, they're going to want to turn around and double check the blood glucose, and we'll have them do a second test. So they probably want to just be really sure that it wasn't just issues with the test. They're going to repeat the test again and do it. How now you cry.
Professor, I'm confused. So
Sure, Anna.
the first time you said that as long as it spikes at an hour and then it goes down. So that's okay. That's what you want to see. Is that correct?
For the first one? I'm not sure I understand.
Yeah,
your
when
question.
you do the 1 hour and it's 180, you expect to see the spike and then it will go down for hour 2 and 3, correct?
It should, if you don't have gestational diabetes. But if at the 2-hour marker you're still above the 153, that's an indication that you may have gestational diabetes.
Okay, so
Anna,
and they would-
the
155.
1 hour test, you drink the drink and then you only get your blood drawn once. It's
I understand that.
the 3 hour that has
Well,
the.
how can that be?
What
How
do you
can
mean?
that be? Because they're screening it at 1 hour and then they're doing it at 2 hours.
They're not for the 1 hour. You drink the drink at the beginning and then you only get your blood drawn once, unless because the 1 hour you don't fast for, so you just get your blood drawn once. And it's the 3 hour that she's talking about, that you have a fasting, a 1 hour, a 2 hour, and a 3 hour.
Right.
For the first, it is my understanding that for the one step approach, you fast overnight, you consume the glucose. Then they check 2-hour increments.
So
Okay.
at the 2-hour increment, they don't need to draw your blood again? They use the same blood?
No, they should be drawing your blood again at the 2 hours. Otherwise, they won't know
Right,
how.
That's what I thought. Thank you.
So
That's what I was confused about.
I've worked for Quest in for the 1 hour you don't have to fast for, and it's only one specimen. It's the 3 hour that you have to fast for, and it's 4 specimens of fasting 1 hour, 2 hour, and 3 hour.
Now, is that different
that's-
clinic by clinic though? Does it depend which clinic you go to though?
I
If
think
how
all the
they would
labs,
do it?
I think all the labs are different because I worked with Waterbury Hospital and we did ours different. So I think it all kind of depends, and it pretty much all depends on what the doctor wants too, because the doctor will write an order and say, I want the patient to do the 1 hour, the 3 hour. I want them to fast and or non-fasting. So pretty much, I think it all comes together with what the provider orders.
Okay, that makes sense,
That's what
actually.
yes, that's what I was gonna say. Is it depends on what the order is. So a lot of times we see what they do, they may order the one step approach. What the standard is that they generally will do the one step approach. For women who don't expect to have gestational labor, it's a regular screening. Would they do a two-step approach for somebody who they already suspect has diabetes? They know that it's probably already going to be elevated, but they want to see what's going on. So they may skip the one-step approach. You don't have to be responsible for ordering the test or knowing why they order the test, because that's out of your scope of practice. Okay. What I just want you to understand is this is what the book says pretty much about the one step. And the thing that I want you to take away and what I want you to understand from this is that we expect that a body in a normal person, right? When we eat food, we are going to see that the blood sugar goes up. Is that correct? Right? And that's why we said, and that is why we check the patient's blood glucose level right before they eat. Taking the blood glucose after they eat is going to be elevated. So it's not a good indicator that they have diabetes, right? We would expect that you've just eaten some food or you've eaten some candy, so the blood sugar would be up. So generally, what you want to turn around and look at is what they're doing fasting, and see if they're able to break down the sugars. Okay, so don't get hung up on all the little details. What I just want you to make sure you guys are aware of is that it's elevated. So the next slide says non-fasting for the first step. So that is the first step of the two-step approach. Okay. It's right in the book where I got the information for, so you can read it again if it's not making a lot of sense. But again, you guys aren't going to be diagnosing the patient with diabetes, gestational diabetes, but I want you guys to recognize that a level at 180 at 1 hour, or still above at 2 hours or 3 hours, that is still high, is going to be suspicious of gestational diabetes. Does that make sense? Everybody got that part? Okay. All right. So what are we going to do when we have a mom that does develop gestational diabetes, or has diabetes already throughout the pregnancy? We are going to do a lot of the same things that we are going to tell a person with diabetes to do, right? The one difference when we have a woman that is pregnant is that we have to worry about the baby as well. What are we going to give them? What can be harmful to the baby? Because you're not thinking about just the mom in this situation. So you're going to be worrying about your pregnancy class of the medication that we are going to be giving them. Okay. So a lot of times we can treat them with diabetes, exercise. Sometimes we would be giving them glyburide or Glinase. Women who have diabetes prior to becoming pregnant, that are on an oral anti-diabetic medication, may continue on with these medications. And I think somebody else was talking about metformin. They are relatively low risk for injury to the unborn fetus. So it is okay for them to continue on these medications. Sometimes the provider will say, nope, I don't want to take any of the risk, and we're going to switch them over to insulin. Okay. So we're generally going to be able, think about switching them over to insulin when we can't control their blood sugars, and we see that their blood sugars remain elevated an hour or 2 hours after they eat. Okay. Does that make sense? All right. So what is glyburide or Glinase? It's an anti-diabetic or oral anti-diabetic medication. It is pregnancy class 3. So there is some risk to the baby, but not a heck of a lot of risk. So it may be something that they can still continue to take. All right. And in a person who is not pregnant or pregnant, you can experience hypoglycemia if you take too much medication or not enough food. Does that make sense? So that's just like our patients who we give these medications for. We want to tell them that we're going to take these medications with food. Why? To prevent episodes of hypoglycemia. All right. It can interact with alcohol. A woman who is pregnant is hopefully not going to be consuming any alcohol. But the thing that happens with alcohol is it's going to lower the blood sugar even faster and even more. All right. Some of the side effects can be weight gain, an allergic reaction, GI distress, your diarrhea, just like your metformin, and it can have a harmful effect on the liver. All right, what are we going to do when we have a mom with gestational diabetes? We are going to be watching her much, much more closer, right? They're going to do more screens, generally between 60 and 20 weeks of gestation, and they're going to be watching for, frequent stress tests, and they might be doing more ultrasounds. All right. The nursing process and the treatment for diabetes type 1 and type 2 are going to be very similar to what we are going to do for the mom with gestational diabetes, right? We are going to be watching their blood sugars. We're going to be, they may be doing it more frequently. We're going to watch their diet, their exercise. Okay. Any questions about that? I didn't put all of the steps back in because I think by now you guys know how we are going to treat those patients. And based on our conversation at the beginning of the class, you did have a good retention of the information. Okay. Any questions about gestation? Was there a question? All right. So the next exemplar is going to be for peripheral neuropathy. All right. Patients who have uncontrolled blood sugars are going to develop peripheral neuropathy. Otherwise they call it diabetic neuropathy. Okay. A patient can have neuropathy without having diabetes as well. All right. So peripheral neuropathy is a result. It can become from trauma or it can be from disease. And what happens is the peripheral nerves become damaged. All right. The effectiveness of the blood vessels become decreased. The blood vessels constrict to divert the blood into the larger blood vessels. So they're going to have trouble with circulation. And the nerve endings suffer from the decreased blood supply. So that's going to cause damage and decreased sensation. Okay. This is just the pathophysiology and the etiology. You guys don't have to memorize that, but I put it there just in case. What I want you guys to be aware of is that patients who have diabetes are very commonly have peripheral neuropathy. It's one of the things that you often see. And one of the reasons you often see that the diabetics have amputations or other complications, peripheral vascular disease can impact it. All right. Alcohol. There's other reasons why a patient could have peripheral neuropathy, alcohol abuse. You don't need to know the pathophysiology. I just put it there. Yep. and vitamin deficiency, especially vitamin B. And one of the side effects of metformin is vitamin B deficiency. And so you will often see that they do give vitamin B along with metformin because it can make the neuropathy even worse. Okay. Immune suppression, autoimmune disease, toxins, kidney, liver, or thyroid disorders, age and height can also impact your risk for developing peripheral neuropathy. And one of the things that we are going to do to try to prevent peripheral neuropathy from developing is controlling the patient's blood sugar. All right. We're going to make sure that they get a lot of vitamins, fruits, and whole grains. We may give vitamin B12 injections, and that is used to help the tingling in their feet. Okay, if we have a vitamin B deficiency, and sometimes with certain conditions, we cannot even absorb or use the B12 in a pill form. So that would be why we would be giving it to them in an injection. Okay. One of the things that I give to my dad frequently, usually once every 10 days, is a vitamin B12 injection. And he knows that he's ready for a new one because he feels the burning and the tingling getting much worse. Okay. So I would go and I give him the injection, and it helps with the treatment of the neuropathy. All right. In order to prevent neuropathy, the neuropathy, we want to try to decrease the risk factors such as the repetitive motions. Smoking can impact the circulation, toxic chemicals, and cramped positions. Okay. So what are we going to see in our patients who have neuropathy? It tends to affect the nerves, right? So the signs and symptoms that we are going to see depends on which vessels have been damaged, right? So there's going to be polyneuropathy, which is distal paresthesia, which meaning distal meaning where? The feet. They have numbness. You're going to feel that they're aching, they're burning, or they have shooting pain, and you're going to see that the feet are going to be cool to touch. All right. This impairs the sensation to the person's foot, and they might not feel temperature. All right. And that's going to be important to remember when we talk about making a care plan for these patients. All right. With diabetes, neuropathy, or just regular peripheral neuropathy, it tends to start at the lower portion of the toes, the feet, and it works its way up. You're going to see that also can happen where? In the fingers, and it can work its way up the arms. You're going to be working with multiple people to try to minimize the patient's discomfort with having the peripheral neuropathy. A lot of times you might even see a neurologist who can get involved with it, a diabetic educator who is going to help work with the person to try to, manage the complications of the peripheral neuropathy, right? You're going to see that diagnostic tests can be ordered for them. They want to see if there's conduction where the nerves are going, right? So you're going to see electromyogram. They might also do a white blood cell count, thyroid functioning. They're going to check your vitamin B and thiamine levels. They may order a metabolic panel, some urine screening. They can do a biopsy, and they're going to rule out other conditions that might cause neuropathy, such as Lyme or HIV. Okay. Can they do surgery to repair it? If a person has damage for medical reasons, you know, like a tumor or carpal tunnel or nerve injury, they can repair it. A lot of times when it's prolonged, like within diabetes, they don't do surgery and they treat with medical management. Okay. So what are we going to see that is going to be prescribed for these patients? We are going to make sure that we give them medications, you know, to relieve the pain. You will see that they're ordered pain relievers, anticonvulsants, antidepressants, and lidocaine patches. One of the most common medications you guys probably have already seen is going to be pregabalin or Lyrica or your Neurontin, right? Does that make sense? Has anybody given these medications out? All right. And why do we think we're going to give this medication versus giving them an opioid or an anti-inflammatory? And this is the important part I want. Better effect on the nerve pain. Yes. All right. Good. So what I want you to know is that this medication is going to be helpful. And we have to do, what are we, you know, how are we going to use this in the nursing realm and environment? When we assess the patient's pain, what is it going to be important that we assess for? The quality, exactly. And Megan, what do we expect? Yes, James got it. Burning, tingling, numbness, right? And the location, as Nwid said, right? Because we want to know the difference between the type of pain that we're working with, right? When we think about bone pain, that's going to be a deep pain. When we think of muscles, that's aching. And when we're talking about these descriptive characteristics of burning, tingling, and numbness, that's telling us that there's problem with the nerves. That's nerve pain. So we're going to use something that's going to work along and treat the nerve pain. Okay. All right. So it's pregnancy class C. So it might be something we're going to use cautiously in somebody who also has gestational diabetes. We don't expect that they would develop this peripheral neuropathy, right? Because the complications are going to, you know, develop over a long period of time. But we might have somebody who has been a diabetic for a period of time prior to conceiving and might have neuropathy to begin with, all right? It is important to watch the patients who take these medications because they're a great risk for renal failure or congestive heart failure. It also can put them at risk for developing depression or suicidal ideation. Okay. All right. So what can we do besides just giving them pain medications? You may see that a person will be prescribed physical or occupational therapy. We want them to, you know, eat well. We want them to try to lose weight, avoid those risk factors such as smoking, alcohol, and exercise. A lot of people say, oh, my feet hurt, I can't get up and I can't move. We want to make sure that, you know, they are getting up and moving because that's going to be very, very helpful. And daily foot care. All right. Other things we can do is nerve conduction, acupuncture, massage, and biofeedback. All right. So what are some of the lifespan considerations? Patients with diabetic peripheral neuropathy generally does not occur in children because they have not had the long-term complications or had the damage done to the blood vessels yet. But if we see that a child is not controlled early on and they have poor glycemic control and they have had diabetes for a longer period of time, they might be at risk for developing these neuropathies. Okay. So what are we going to be assessing for? Part of our assessment when we have a patient who has peripheral neuropathy, can you think of another concept that might be, that go hand in hand with this? Mobility, yep. What other ones? Tissue perfusion, pain, safety, perfusion, yep. Mood and affect, yep. Nutrition, patient education, regulation, metabolism, yep. And the the big one that I haven't seen yet is sensory, right? So we always want to make sure, because that's going to impact our safety as well, right? We want to watch how the patient is able to walk around. If you can't feel your feet and don't know that they're underneath you, you're not going to be very, very steady, and you're going to have issues with balance, right? But also, if your feet are burning or hurting with every step that you're taking, it's going to be very challenging. Okay, we're going to assess their mood, their anxiety, their ability to perform ADLs, any sexual activity. That's going to be with your patients with diabetes as well. Assess the medications that they're taking and any hazards. What do you think might be another hazard for somebody who has peripheral neuropathy? Something that we do every day. Showering, walking, cooking, hygiene, driving. That's the one I was going with, Sandy, is making sure if you can't feel your feet and you don't know how you're pushing the gas pedal, that can be pretty dangerous. All right. All right, physical assessment. We're going to check for peripheral pulses, for circulation,
Professor?
gaits, pressure. Yes, dear.
Yeah, I think you also like want to check the shoe that they wear for like any objects in it, because they won't be able to feel it. That can cause like a pressure
That
sore.
Yes. So we're going to do an exercise next. We're going to develop a care plan for the patients. And I want you guys to, there should be a handout here, and I'll go over that quickly. But that's going to be very important with the shoes. Okay. Nursing diagnosis, we're going to talk about risk for injury. You guys said that. Perfusion, pain, anxiety. All right. Prevention of injury, we're going to try to keep them free from falling or getting hurt. All right, we're going to teach them about exercise, smoke cessation, avoiding of chemicals, avoiding alcohol, avoid repetitive prolonged procedure, pressure, and massage, right? We're going to talk about using the pain scale. So we want to make sure we use the pain scale consistently with them, and talk about the quality of the pain, as you guys, mentioned. We are going to give them pain medication as needed on the schedule. And we also want to make sure that when we evaluate them, or when we give it, that we follow up with the evaluation process, making sure that the pain is controlled, making sure that they're able to get some sleep and be comfortable, right? So we're going to follow up after we give them the pain medication and evaluate to see, is it helping, right? Okay. So I think that was Carice who was talking about what we were going to be teaching them. All right, so here we go. So what we're going to do now for an activity, and I want to make sure that you guys know that this activity is going to be directly helpful for you when taking the test next week. So I strongly suggest that you stay and participate and listen to the answers that are provided. Okay. So what I'm going to do is where's this paper? This paper was in the in-class activity. You're welcome. Okay. So I'm going to divide you guys into 2 breakout groups, okay? Group 1 is going to, during the session, you're going to work on peripheral neuropathy. And then the second half, group 2, is going to work on the gestational diabetes, okay? So what you're going to do in your groups is to look at the pathophysiology. What I want you guys to do is use layman's terms. How would you explain this as a nurse to your patient, right? We want to be able to teach them in a way that is easy for them to understand. And that's why I didn't focus in too much on the etiology and pathophysiology from the book. I want you guys to be able to talk about and teach your patient. Okay, you have peripheral neuropathy. What does that mean? How did I develop this, right? We want you to develop in the next column, you see my hand here, the clinical manifestations. What do we expect to see in our patient, and what would it be that we are assessing for? We then want to talk about treatments, right? What are the possible treatments to be considered for this condition, and what would we use? What are some goals? What are some short-term goals? What are some long-term goals? And what will we then teach our patient? Doesn't this sound like your clue, your concept map, right? So this is helping you to, separate this information from other conditions when you see your patients with diabetes that have so many comorbidities that are happening, right? The people who are in the second breakout session are going to be doing gestational diabetes. And I want you to do the same thing. Utilizing layman's terms, how would you teach a person if you were going to work in an OB clinic or doctor's office and the patient just told your patient, oh, you developed gestational diabetes? What are you going to say? How are you going to help them? What do we expect to see? How would the patient be presenting? What type of medications would we be using? What kind of goals would we help establish for this patient? And what are we going to teach them? Okay, are there any questions about that so far? All right, so I'm going to break you up into breakout groups. I'm going to allow you guys to work till 11 o'clock. All right, at 11 o'clock, we're going to be pulled back into the group, and I'm going to ask one person from each group to share the information that they have, or it could be a team of people that are going to bring their screen up. So actually type it into this into this paper, and then you can put it up on the screen, okay? So you back here with me?
Yeah.
Yep. Yes.
Okay. Somebody in group 1, do you guys have the option to share in your app over there on the bottom? Looks like next to the chat, it tells you participants there should be a share content button.
I see where it is. I wasn't the designated recorder, but I did write some things down, if that helps.
Can the recorders of each group send it to me real quick in an email, and then I'll post it up if you aren't able to post it and share?
I think I can share mine.
Okay, perfect.
No, maybe not.
Let me know if you have any issues, because I can also share mine. It's just probably not as organized as yours.
This has to be in a PDF, I believe. Sometimes a Word document, it's crazy in order to upload it up here. It's going to be saved as a PDF first.
That might take me a minute.
This is Heidi, Professor. I'm gonna send over the group 2.
Group 2, okay. Can somebody say group 1? And I'll make it a PDF real quick.
I'm sending you this in a PDF. I already did that part. I just can't share it.
Wonderful,
Yeah.
Heidi. You make life easy for me.
I try.
Can somebody do that? Can somebody do that for the other group? And then I can share it, okay? Thank you, Irina. And that way we could post it.
Did you get my email?
I did.
Okay, great.
Something went wrong, of course it went wrong. Can't seem to get it to come up. Cannot get it to come up here. I gotta make sure my attachment is safe. No. I didn't get it, but I'm gonna post back up mine here. Okay, so we're gonna start with group 1. Right, so I would make sure that if you guys didn't write it in, that you guys have this information because it's gonna be very, very helpful to you, okay? So the person from group 1, do you wanna turn around and talk about the pathophysiology? How would you're in the hospital and you're teaching your patient about diabetes? Type on it. Can you type on this one here? There you go. Can somebody, I don't know if anybody else can type on it. All right, do you want to share and I'll write it in here?
I think probably the main gist that we kind of got together as a group and decided on in terms of layman's terms is describing that it's a trauma, it's an injury that's caused by your nerves or blood vessel damage. It causes weakness and numbness and pain from nerve damage, and it usually affects your hands and your feet. And definitely relating it to whatever their current condition is, whether it be diabetes or Lyme's disease or, wherever their, cause is, their etiology, and using that to explain.
Awesome, good, right? So the key the things that you want to talk about is an injury or trauma. And I think you put it in nice things and you talk about hands and feet. And that's the key when you talk about peripheral, right? Peripheral meaning out in your peripheral, nothing close in. Right, and you said what, numbness and tingling, right?
Yeah, it's trauma and injury causing nerve and blood vessel damage that causes weakness, numbness, pain. In your feet, hands.
Yeah, and it's the funniest thing because I always ask is, my dad has it really, really bad. He was like, "Oh, my feet are numb, I can't feel it." Well, how can you not feel your feet? But yet, at the same time, you got the burning and the pain. So it's like you can't feel the outside of your foot, but you can feel the pain going almost up the foot, and burning. Almost like if you think about your phantom pain, if somebody has had an amputation, they still sense the message from the nerve is still getting up to their brain, right? The foot's missing, but you still feel the pain because it's going along the nerves. Okay. All right, and Ryan, what about treatments?
Passover manifestations go to treatments.
Oh,
I guess
did you do
we talked
manifestation?
about manifestations. So treatments.
Yeah, the numbness, the burning, and the thing. That's what I thought. I just put it in the wrong spot.
Treatments are everything from medications such as antidepressants, pain medication, everything from anti-seizure medication, pain relieving creams, nerve pain like gabapentin and things like that. But also transcutaneous electrical nerve stimulation, plasma exchange, intravenous immunoglobulin, physical therapy, surgery. Anybody else in group 1 have stuff that I didn't write down?
I just had, all
The
those
B12.
obviously avoiding, oh no, that was different. Yeah, avoiding smoking, really assess even like non-pharmacologically, what is their diet like? Have them avoid alcohol and smoking, things like that, regular exercise. And then I think Ryan covered the rest of it.
What about goals? What do we want to do for this? Like, what is the expected outcomes for this person? Like, what can we do for short term, long term?
We want to prevent injury and possible, amputation could be the worst case scenario. Falls, and as you had mentioned in lecture, safety is a huge priority with these patients, because if you can't feel your feet and you're walking around, you can step on something or burn yourself, or or even if you're driving, that's really not a good situation. So you want to really restore some kind of, their activities of daily living in some way without harming them, and then control the pain.
Yeah, no, I only laugh because my dad he didn't want to give up his independence, and he's like, yeah, no, I'm going to drive. And I'm like, why don't you let me drive? And he's never let my mom or myself drive ever. And he's like, nope, I got it. We're sitting in the car and he's got it in park and the engine is revving. And I'm like, we're taking those keys away from you. We don't want you to hurt yourself or anybody else. And that's very, very important, because safety is big. All right. What are we going to teach our patients?
Managing blood sugar levels, how to follow a healthy diet. We need to educate them on the necessity of exercise and trying physical therapy, reducing exposure to toxins, quitting smoking, managing stress, how to lower their pain naturally, how to check their blood. Oh yeah, we did that. Protect skin and feet.
Don't walk barefoot. So that's important. What about foot care? What kind of foot care do we want them to do?
Trim their nails with the podiatrist.
Yes, only have no pedicure, right? The podiatrist is going to do that. What other things?
Section of the foot.
Yes, inspect the bottoms of the feet, not their bottoms, right? Okay. Other things that are no lotion between the toes. Exactly. And why is that, Sonia?
Probably because it softens the skin.
Yeah, it's fungus or moisture, right? You got to clean between the toes. Yep. More warm, moist environment. Exactly. Other things that people tend to do, especially in a pedicure, is not to remove calluses, right? Other things that you think about for safety is if you can't feel your feet, how do we normally go in and check our some places shave their feet to get the calluses open, and they're going to be bleeding, right? Or they won't be able to heal. When we go to take a bath, right, or go in a hot tub, we normally put our feet in first, or we put our fingers in first, right? If we can't feel our fingers or our toes, how do we know that it's illegal in Connecticut? I'm guessing the shaving, right? Is that what you're talking about? Yeah. You can't feel the water temperature. So making sure that we set our thermostats on our hot water heater, if we have that, or even use a thermometer in the bathtub. If you stop and you think they're, even if you're going to help your grandchild, I'm going to give them a bath, and you go and you put your fingers in and you're like, oh, this water feels great. And then you go and you put the child in, they may be burned. Okay. Because they don't know. So and then good footwear. There was a case of a lady that lost her leg from a pedicure. Oh goodness, yes. I remember going once and the person cut my cuticle or my callus, and then she started blowing on it. I'm like, gross stuff. Yeah. All right, great. Good job, guys. This was really nice. Do you find it helpful to try to compartmentalize? When you can teach somebody the information, then you know you have a good understanding of it. All right. I hope everybody participated in like this exercise. Good, good. I'm glad. It helps to tie it in. You're going to be comparing and contrasting. All right. Next, gestational diabetes. Okay. Who wants to present about that?
Let me just try sharing my screen one more time.
Yeah, try sharing. I could try to download it again, but it keeps telling me that the extension is not safe when I try to
Oh,
open
you know
it
what?
or
Maybe because you're the, yeah, it doesn't let me share. What if I just did a screenshot?
screenshot it and send it to me, then I can probably. Because when I think I got it, guys. I got it. Hold on.
I think I
It
can't share
opened.
because you're the moderator.
Yeah, well, I kept opening a blank one and I finally got it. So open. Let's see if I could get it here and then save it as a PDF. There we go. Hold on, I got it, guys. I can bring it up. I like that, I think it's more helpful for when you guys do active information and doing it, because it can be boring for us me to chit chat here. Okay. All right, let me see now. Where are we here? We're here. And I'm going to stop sharing this. Add a file. Let me see if I have it here. I'll upload here, and then you guys should be able to see it in just a second. What I get is a blank.
What if I
That's
send you the
mine.
Word document?
When I got, let me see, let me save it here real quick. This, let me go back. And I'm going to add a file. Okay, let's see if it comes up.
I just sent you the Word document too, if you want to try that in PDF.
Is that
Oh,
it?
there it is.
There you go. Okay, nice. All right. So Heidi, you want to get there sooner than later? All right. So you want to share with what you guys came up with the gestational diabetes, or anybody in the group?
So we'll explain to the patient that it's frequently caused by the metabolic changes due to the changing hormone levels because of the pregnancy, and that your body's looking for more glucose for you and the baby for energy. And it's sometimes, even though you may not have known you were diabetic, it may present with gestational diabetes.
And it may also exacerbate if you had the
Right.
diabetes previous, right? And then the change makes it worse, right? Okay, good. All right, some clinical manifestations that they should be watching for, or things that you will see.
Anyone else from group 2 want to chime in? I feel like I'm, taking over. And we know I have, power issues.
You got this. All right, go ahead.
All right. So the patient will likely be thirsty. We'll be looking for the 3 P's of diabetes: polyphagia, polyuria, polydipsia. Checking the fetal growth, bundle height. Typically, a patient with gestational diabetes will have a larger than expected child. Monitor the A1C. They could also present with hypertension, neuropathy, retinopathy. We're going to do a urinalysis, monitor their diet, exercise, check for family history of diabetes, signs of preeclampsia, history of PCOS, and the glucose tolerance test.
Good. All right. So you see it. All right. Then, and then the treatment.
Metformin or glyburide, and then if those are not effective, insulin. We're also going to make sure that as an intervention that they're maintaining a healthy diet and exercise, and referral to a dietitian if required. For the goals and outcomes, we have.
Yeah, and so I just want to make sure also that you're aware, like some providers might just switch them automatically to insulin if they need it and don't want to run the risk. Typically you will see that metformin and glyburide will be for those women who probably already have PCOS or diabetes. They might just keep them on that and switch over to insulin if need be. Other providers, might just start them right off on insulin. Does that make sense?
Yep.
Just because of the possible
So if
risk.
it's new onset and it came about because of the pregnancy, they would typically start with the insulin. Is that what you're saying?
Yes, they could. They might, you might have a mom that says, no way in heck am I gonna turn around and give myself insulin. They might then turn around and say, okay, well, there's minimal risk of injury. We might turn around and start off with glyburide or metformin. What I want you to take away is that those are the options to turn around to lower the sugar. And sometimes a healthy diet and exercise with somebody might not even warrant them to need insulin. Does that make sense?
Yeah, so they pretty much have like the option. Like first they could try the healthy diet, the exercising, see if the levels decrease. And then if not, then that's when they'll like pretty much try to push the medication, because now it's like getting dangerous.
Right. Yeah, it's the same thing just like with type 2 too. I mean, it doesn't necessarily mean you automatically will have to have insulin. You always want to assess the person and assess the patient individually. So that's the thing with nursing. We aren't going to say a steady, hard, fast rule that we're automatically going to give them insulin, because the patient has the right to refuse to take insulin, right? As long as they know the complications that can go along with it. They might just turn around and say, oh, you know what, I'm not going to take any medications, or I'm not going to take the metformin because it may harm my baby, and immediately go to the insulin. So we're not going to be the ones prescribing the medications or determining what's right or what's wrong. I want you guys to have an understanding of why they might use it. Does that help? Yeah. Okay. All right. Perfect. All right. Outcomes. I like this that you started out with the patient will. There you go.
So on a later version after I sent this to you, I changed that to a range. Patient will maintain a blood glucose level of 100 to 130.
Yeah, that was my feedback.
Patient will maintain an A1C of 67. Patient will understand healthy diet. Patient will participate in a daily exercise program.
I like that. And it is the range because, right, we want to try to, we understand that they might not be perfect with their blood sugar, but we want to try to keep them within a normal range to prevent complications to themselves or to the unborn fetus. So why so high for a glucose? This, I would say it would tend to be lower if it was a resting blood sugar. We would expect the range to be, we want them to be as close to normal. Yes, and they allow up to 7% for the hemoglobin A1C. They do that with patients with diabetes as well. Now that they allow the hemoglobin A1C to be a little bit higher, because they expect that a normal hemoglobin A1C in a diabetic patient is not might not be feasible. Okay. All right, I missed the last comment. Okay, and so we got to teach them how to check their glucose, right? Because this person has, when you talk about gestational diabetes, the person has never been a diabetic before, so they don't know how to check their blood sugars. We got to get them a monitor. We got to talk to them about it. We got to teach them about the medications, how to prevent hypoglycemia. That's great. Those are good things. Yeah, I'm sorry, I took over. I have control issues too, apparently.
I don't care. You can read it. So we're going to teach the patient how to self-administer the meds, including taking it with food to prevent the hypoglycemia. Teach them about healthy diet. Seems repetitive, but teach patient how to participate in a healthy exercise program, how to recognize signs and symptoms of both hyperglycemia and hypoglycemia. Teach the patient about potential adverse reactions to meds. Make sure she keeps some fast-acting carbs on herself at all times in case she does become hypoglycemic. Teach her about the signs and symptoms of preterm labor, contractions, bleeding, etc. When to call the provider, and also the importance of regular vision checks.
Very good. I like that. That was really good. The importance, you also have here the signs and symptoms, how to recognize the signs and symptoms. We want to make sure that they know what to do about it. Well, so if your sugar's high, what are we going to do? We're going to take insulin or other medications to lower it. If we're low, that's where your rule of 15 might come in into play, right? We also not only need to teach them how to check their glucose, they might need to know how to administer injections. So if we're going to be giving them insulin, we need to teach them how to draw it up and how to give it to them. And the sad thing of it is like now a lot of healthcare providers, they're limited with how much time they spent with a patient. And they will just say, oh, you know, here, I put in an order for insulin for you, and I put an order in for some syringes, and figure it out. You know, X amount of, insulin here or there, and they don't take the time to show them. And you can imagine the potential complications, or how unsafe that is to give somebody a vial of a medication, without knowing the difference between units, or how to draw it up or there. It could be fatal to the patient. So it's going to be very important. Even if these patients aren't to be in the hospital all the time, they might be outpatients. So if you're working with them in a doctor's office, that might be something that you will be responsible to teach them, because the doctor is going to say, okay, make sure they understand and how to do it, and make sure that they can show you and do a repeat demonstration of checking their blood sugar in front of you and not. And it might be also something that you do see in the maternity ward, or you have a patient who comes in on the medical unit with high sugars, and we need to take care of them. We might be needing to show them how to do it. And that's the important part of nursing, is you guys, are getting to the point now where you guys are just getting comfortable with giving the injections yourself. You got to take it the next step further and teaching them how to turn around and do the injection and administer it themselves.
Okay. We, as a group, in the second item of patient education, self-administering meds, we kind of thought that was all covered, the whole drawing up the meds, etc.
Oh, yeah. I'm sorry.
That's okay.
All right.
Does anybody want me to post this page, because I can condense it to one page, and like the group discussion, the class discussion? It'll be a PDF, but I think that'll maybe help. Okay, happy to.
The other thing you could turn around and do, Heidi, which might be easier, is if you go to the messenger and send it to all students, and then you can attach it there. Because I think the discussion of those other areas, it's very hard to upload a folder, a file. I know in announcements we have a hard time with that, but you can send it out.
Okay, and maybe whoever actually typed the group one could also do that.
I hope you found this activity to be helpful.
I'll try and post group one.
Okay, great.
Thank you, Irene. Tomorrow, we're going to be doing, we covered the neuropathy here. I took the half hour. I thought it was best to combine the gestational diabetes and neuropathy together, just because that seemed to make more sense. And tomorrow we're going to be talking about violence. So there's a PowerPoint there. And then there's 2 group activities, I believe, in the in-class discussion. So you want to make sure you have printed those out, because we're going to do the breakout groups and then share as well the information that we have. And it's going to be an interactive discussion as well. Okay. Thank you for your participation and sharing. Is there anything in particular that I would focus in on this activity here? If you have an understanding of these 5 columns in each one, I think you would be doing pretty good, knowing what the signs and symptoms of gestational diabetes. Second page is you got
Karina, I will be emailing that to the class. And I think I can do it in a Word document, so you can just save it. Okay.
Right, everybody, other questions before I sign off?
So you said just pretty much focus on the symptoms, the signs and symptoms.
The 5 columns here, you want to make sure you have an understanding of what it is, the clinical manifestations, the treatments, knowing what to do about it and how to recognize it. I think if you have a good understanding for these, group 1 and group 2's discussion, I think that would be very, very helpful for you. So you don't need to memorize the sugar levels. You need to be able to identify. You need to identify what would be indicative, of a person who is experiencing gestational diabetes. You need to know that what might be an abnormal reading for an oral glucose test. And somebody asked if it's just a high sugar that is the problem with gestational diabetes. And if you look under the pathophysiology, it talks about hormonal changes and all the complications and the changes that happen during pregnancy that may impact it. So it's just not caused by high sugars.
All right, so I just sent the email and it's in the messages, course messages, not the discussion.
For violence, your violence is going to be covered on the test as well.
I see it there, Heidi. Thank you.
All right, you got it.
Bye, everyone. Thank you.